Hello again, and welcome to another edition of MD, PhD, ETC lecture series. I'm Robert McClay, MD, PhD, ETC, Doctor, Captain, Doctor, etc. And today we're going to continue our talks on the Intro to Psychiatry series, as I'm a psychiatrist. And more specifically, we're going to talk today about anxiety and anxiety disorders. So anxiety is interesting in that it is both a normal feeling, sometimes a healthy and adaptive feeling. It can be a symptom of other conditions, and it can be part of what defines a condition in and of itself, what we call essential. The same way when we talk about essential hypertension, we mean a condition that really can't be explained by anything else, and therefore we're just going to treat it in and of itself. So in terms of normal anxiety, we all experience this. This is something I don't think, well, maybe there are somebody, the man without fear, right, Daredevil. But most people at some point in life have felt some degree of anxiety. I may have some anxiety here about, am I going to say too much? Is there going to be something in the background that's goofy? I've been up for like 36 hours, so do I have bags under my eyes? So, we all have some anxiety about things that are perfectly natural, and it's adaptive in a lot of ways. We should feel anxiety from a very early age. We are trained to be afraid of some things because otherwise that they will kill us. If we weren't afraid of the big scary snake, maybe we would have been bitten and died. Maybe we would have just casually walked off a cliff. And anyone who has had a toddler, I'm sure, is familiar with the fact that the first about year and a half of them first learning to walk is an experience in the toddler finding things that are dangerous and could hurt them, and mommy and daddy pulling them back. And how that ends up building anxiety we'll talk about in a little bit. So it can be a normal, healthy, adaptive thing, but it can also be very painful and very distressing and a symptom of sometimes of something else. For example, with depression, people who are depressed for long enough start to feel anxious, and that may be because of a biochemical similarity. It may be just because if you're miserable for long enough, you start to feel these things, depression and anxiety. But it can be a symptom of depression, and we use that as a modifier for, say, a major depressive disorder. We say major depressive disorder with anxious symptoms. But also, there are conditions in which anxiety seems to be the main problem. And if you look at main problems in psychiatry, we have this book, the Diagnostic and Statistical Manual. And if you haven't seen my earlier lectures on sort of how psychiatry works and depression, because I use that as the case example of understanding how psychiatry defines things, I do recommend looking at those first before this lecture. But just to review, basically we have checklist diagnoses, which we use to define syndromes to be able to help our patients to say, okay, your anxiety or your depression or whatever looks like this. And by defining it very well, we can use that to say, well, if your depression looks like this other person's depression that was defined the same way, then what helped the other person might help you. So if you go out into the world and you go through this whole thick book, and you ask people all the questions, do you have these symptoms? And this actually has been done, by the way. There's something called the ECA, or the Epidemiological Catchment Area Study. I have no idea where they came up with that convoluted name, but nevertheless, they did go out and they asked people in lots of different areas of the country all these things, and a number of other issues as well. And when you do this on any sort of scale, you'll discover that anxiety disorders are the most common psychiatric problem out there, affecting about 18% of the whole population. So at any given time as well. So that's pretty dang common. But it's not the reason that people come into psychiatrist's office most often. That's depression. So why are these so common? Why do we consider them abnormal at all? And how do they end up being so common without getting treatment? Especially considering they're very gratifying to treat because these are very treatable conditions, often in fairly quick, simple, and very effective ways. Some therapy techniques have 95% plus effectiveness in wiping these conditions from the map. So why don't people come into our office? Well, because for anxiety disorders, we tend to avoid what we're afraid of. And that ends up being probably a way that these get perpetuated. Probably a lot of things that we're afraid of are learned logically by the fact that we avoid things, that we were trained at an early age not to wander to the edge of the cliff. So even if you don't have a full-blown phobia, most of us, a toddler will walk right off a cliff. But by the time we get to a few years older, when we get to the edge, most of us will get that queasy feeling, and our brainstem has learned to be afraid of this and sends out physical symptoms. Palpitations, muscle tension, that creepy crawly feeling, your stomach does flip-flops. It says, don't do this. This is dangerous. And that's because you've been trained that it's dangerous. Mom, dad pulled you back from the edge, right? Told you not to do that. Taught you that, hey, if you fall off here, bad things can happen. But let's say you overlearned those lessons. Maybe you got burnt by some hot water as a child, and now you develop a fear of the spigot or of the shower head. Actually run into this one. I don't know if it is related to being burned as a child, but that's one of the ideas behind how these get perpetuated. And we know that essentially that avoidance perpetuates these, but that's the common thing to do. And for a lot of specific phobias, if you're afraid of one little thing, let's say you have fear of spiders, you could probably stay away from spiders most of your life. If you're afraid of heights, you don't have to go up in the Empire State Building. You can even avoid flying a lot of the time if you have that. But again, those are treatable. Now, to define this, by the way, again, we want to say that this is outside of a healthy or cultural norm. That, again, having a little bit of queasiness at the edge of something where you actually could fall off is normal and to some degree healthy anxiety. But if it goes beyond that, if you're actually having impairment, it's causing you constant distress, pretty much every time you would be exposed to this, you would feel highly distressed. It could actually prevent you, say, from going up in the skyscraper, even though you want to very much to visit something on the 32nd floor. Then it becomes a simple phobia, at least if it also persists. Because again, when you actually try to face your fears, a lot of times they burn themselves out. Avoidance will just sort of, if you stop doing it, you're no longer avoiding these things, you get used to it. Public speaking here. I was not comfortable giving these talks when I first started doing them, but I have been giving them for so long that even though there's not even an audience, I'm just talking to a camera, I can do them very easily and I don't feel anxious at all in this moment, even though, again, maybe I actually should, but you got used to it. So, and we'll give people about 6 months with that to define, to say if you've had to have these symptoms, it's above cultural norms, it's causing you significant impairment. It always happens when the fear-provoking anxiety, the anxiety-provoking issue is there, and it doesn't go in 6 months, then you have a simple phobia, and that can be to pretty much anything. Now, some of them we've named in Latin, like arachnophobia is the fear of spiders. Agoraphobia literally means fear of the marketplace, but it's more generally used to mean fear of going out in public. Now, if you look at all of these, and this ties into a Jerry Seinfeld joke that he talked about, that there was this survey that asked people what are they afraid of, and the number one fear in America is public speaking. The number two fear is death. So technically, if you are at a funeral and you're given the choice between giving the eulogy and being in the box, there are a lot of people who would rather be in the box. Obviously, that's a bit of an exaggeration, but it's talking about prevalence. So again, in reality, not about severity, the way it's implied in the joke, the prevalence of social anxiety or social phobia is the most common anxiety disorder out there in general. That people don't like public speaking or in that regard, to the point that it can sometimes look like one of our other conditions, which we'll call generalized anxiety. And we'll talk about that in just a second. But before I do, I want to talk about the treatment of phobia. So in general with phobia, you can cover up phobias with a tranquilizer, with a medication like the old-fashioned barbiturates, pentobarbital, Seconal, or one of the modern benzodiazepines. Valium was the first, the granddaddy of these, or depends on how you look at it, chlordiazepoxide or Librium. But these just sort of numb you out. They increase brain biochemical called, or the effectiveness of a brain biochemical called GABA, which is your brain's main off switch. So it just sort of calms everything down. And with a tranquilizer, something even that is generally fear-provoking, a saber-toothed tiger could jump out in front of you, and if you've taken enough of a barbiturate or a benzodiazepine, you'd be like, hello, but they effectively make you drunk. So they're not an ideal treatment. You might use them, say somebody has fear of flying and they just need to get through an hour flight. Then yeah, I might give them an Ativan that lasts a couple of hours and they just get through that, and they only have to fly once a year. But they're not ideal treatments. If you really want to beat these, the treatment is not medication, it's therapy. And again, it's because the anxiety will burn itself out, at least if there's no actual harm. So if you look at something, say somebody has a fear of bees. If you put them next to a beehive and the bee stings them, you will end up just reinforcing their anxiety around bees, and their anxiety will get worse. But if you put them in a place where there's a glass barrier between them and the bees, well, at first when they come in, they've got a bee phobia, so they're going to, by definition, have these physical symptoms of anxiety. It's going to be overwhelming. It's going to be distressing. Their heart's going to be pounding. They're going to be sweating. It's going to be miserable. But after between about 60 and 90 minutes, that this symptom will just burn itself out, that the body can't maintain that anxiety level. You can only keep the heart beating so fast for so long, you run out of adrenaline, out of noradrenaline, and those symptoms are going to start to fade. And we used to do that literally. That technique was called flooding, is that we would put somebody next to whatever they were afraid of. There was a great Far Side cartoon about this, about confronting your fear of heights, closed spaces, and snakes all at the time by hanging somebody outside a phone booth up in the air in a phone booth filled with snakes. And that would be a very cruel and miserable thing to do, but it would actually be effective. But we don't do it that way anymore. Now we allow people to kind of build up to things and do things that aren't actually threatening. So let's say you have fear of flying. First, we'd have you in a classroom and just talking about airplanes and about how airplanes work and thinking about like why they're not actually going to crash, what the logical statistics are. And after that, we might sort of have you see some planes, like get near them, and or watch videos of people flying. Or if you want to get really fancy, a project I used to work with involved virtual reality. So you put people in a flight simulator, right? And objectively, there's no way you can crash in a flight simulator and actually get hurt. You can crash the computer, but you're not going to blow up and, anything bad's going to happen. So you get desensitized to this gradually over time, and then eventually you get on an actual plane and you fly around until it's fine. And that actually works about 95% of the time. Now, it doesn't always generalize. Sometimes somebody, say, might get used to the plane that they specifically learned to fly in. I am fine on a 747, but I am not fine on an Airbus. But generally, then we can take different variations of this. This is why doing it not just in the physical world, but doing it through imagination and looking at a lot of different variants is an important part of treatment. But it's very, very effective for these simple phobias, whatever your phobia is. Now, let's say that it's not around something you can identify, though. It's just, I feel anxious all the time. You ever met somebody like that? They're just a worrywart. We used to actually say that people had anxious personalities. They ended up splitting that off from the other personality disorders, the things that we sort of consider that you're just kind of born with. Though it does seem some people do seem to be born and run anxious. It does seem to be a personality characteristic, but they broke it off fairly early because we realized that the anxiety part was very treatable. We used to think that the essential aspects of personality weren't. We turned out to be wrong about that as well in a lot of ways. There still are some aspects of personality that are very hard to change. But getting back to the issue is that anxiety turned out to be pretty dang treatable. So, and in a short period of time, even when it was generalized. So we split that off and called it generalized anxiety disorder. Now, to meet criteria for this, it's a little harder to meet criteria for generalized anxiety than it is to, say, meet criteria for depression, because, again, anxiety is normal and often persistent, and there are often syndromes or external circumstances that would cause us to be anxious for a long period of time. So for generalized anxiety, you've got to have this feeling of anxiety the majority of days. It's got to be impairing or causing you significant distress. You got to have physical symptoms. Technically, you got to have at least 3. And it's got to last 6 months or longer. But if you do that, you've got generalized anxiety disorder. And you got something where we can't just challenge a particular fear, get you used to that, because it seems to be there all the time. You're exposed to everything, right? Now, That doesn't mean that therapy is not effective. There's still very effective techniques, mostly in the realm of what we call cognitive behavioral therapy, cognitive thinking about it, basically trying to figure out the pattern to this. Is it really about everything, or is it around something specific? Is it from something from my childhood, or something like that? Surprisingly, by the way, in therapy, people think that we always go back to childhood, and if you figure out what it's from, that we can treat it. You don't generally. As I mentioned with that phobia therapy, it doesn't matter whether you were burned as a child or not. We can still desensitize you to it. But when it's more generalized, figuring out what the pattern is, where this is coming from, sometimes can allow us to address that more specific issue by keeping, say, a log of when you feel anxious and what you're thinking about and what you're experiencing at the time. We can start to identify a pattern. And then we can also learn to adapt thinking techniques that stop us from, say, catastrophizing. When you get into the pattern of being like, oh my God, I feel bad, and now I'm going to make a fool of myself in public, and this video looks awful, and I, you just go through this doom cycle, and learning to break those doom cycles to kind of have self-talk that is more honest and more relaxing, and also to change your behaviors. That's the cognitive behavioral part, is to learn, things like meditation and deep breathing and other things. Learn the pattern that what allows you to feel better. When you start to feel anxious, well, when aren't you anxious? What are the behaviors that let you do that? As long as those behaviors are not horribly unhealthy, like turning to alcohol. Because I did mention earlier the tranquilizers, and you can tranquilize yourself even through generalized anxiety. But the problem with the tranquilizers is that they don't last, and that they often have what we call rebound effect, meaning that even though you feel better in the moment, as they wear off, you feel worse, maybe even worse than you started. This is definitely true for alcohol. So people will get a little bit of Dutch courage or Scotch courage, if you're like me and you like a little bit of a Glenfiddich a little better, and to be able to face that situation in the moment, and maybe that helps you relax or deal with the social situation. But as it wears off, we tend to have escalating anxiety. And if you're having anxiety all the time, not in just a particular situation, and you be like, okay, I need to tranquilize myself, and then that tranquilizer wears off, and I need to tranquilize myself more. Tranquilizers or anxiolytics can be more trouble than they're worth often. It doesn't mean that if a doctor used those for you that they're necessarily a bad doctor. These come in various degrees. There are very mild ones, something as simple as sedating antihistamines such as Vistaril or hydroxyzine can be used to cover up anxiety temporarily and generalized anxiety, to something a little stronger like Klonopin, clonazepam. Psychiatrists are particularly unfond of, say, Xanax, alprazolam, as that gets people in trouble so often around generalized anxiety. But they can be used. But if you're a physician or another prescriber using these, I encourage you to really try to avoid using this type of medication unless you really, really know what you're talking about, because you can get into a lot of trouble with them, both with rebound and addiction and other issues. But generalized anxiety is about the first level at which we really do consider that medications can be first-line treatment. Therapy is still at least as good, possibly better than any sort of medication, but therapy is time-consuming, it's expensive, it's often hard to find a good therapist. So the medications that have really changed the game in this are the selective serotonin reuptake inhibitors, which were originally developed as antidepressants. Well, not originally, actually. The very first one was developed for obsessive-compulsive disorder, which is the subject of a different lecture. But in general, we think of these as antidepressant medications. And for depression, they're fairly straightforward. They increase a brain biochemical called serotonin. And if you look at depression, the major biochemical abnormality that you would find is low serotonin. By the way, you cannot tell this on an individual basis. If you took one person versus another person, the natural variation between individuals is far too much to be able to diagnose depression from biochemistry. So if you're, by the way, at a clinic where someone is telling you that they're diagnosing your depression or anxiety based on a brain scan or a blood test, they're taking your money. At least if this is in the last 20 years from this video, there's nothing along that line. yet, but we can tell in population levels. If you take 1,000 people who are anxious and 1,000 people who are not, you can biochemically tell those two groups apart. And the biochemical abnormality that is present in depression is low serotonin, so you add a medication that increases serotonin, that makes sense. But for anxiety, it doesn't really make sense, because if you looked at the cerebrospinal fluid of 1,000 people with anxiety, the major biochemical abnormality that you would find would be that a chemically related substance called norepinephrine is actually elevated. There's too much of it. It's also called noradrenaline. So you can think about this as a high adrenaline state. Makes sense, right? So why giving a medication that increases a related biochemical, how does that help anxiety? Well, the short answer is we do not know, but the fact is it does work. It works at about the same effectiveness as therapy over time, but it is trickier to use than, say, in treating depression. And we have an idea behind why that might be the case. There are several different hypotheses on this, but I'm going to go to one that I think has a lot of evidence for it. But please do read up further. Also, I like this because even if it turns out the mechanism is wrong, it does give a sense of how to actually prescribe the medications right, which is that how a signal is received is not just a matter of how much of the chemical is there, but also of how much receptor is there. For a biochemical to act, it actually has to hit a receptor, a listening device, basically on the other cell to be able to detect it. And that sends a signal going forward that tells us to be anxious. Well, in anxiety disorders, like generalized anxiety, where you're sort of running high all the time, there's too much of this norepinephrine around, what serotonin may do is end up down-regulating the receptor for noradrenaline or norepinephrine, the thing that there's too much of. It may end up binding to that in a way that says, oh, there's something like norepinephrine here, but it only partially activates it. So when the receptor gets downregulated, the signal no longer comes through as strong. So the serotonin may fool the system into thinking that there's too much norepinephrine around. It downregulates the receptor, and therefore this excess of norepinephrine is no longer causing as much anxiety as it otherwise would. Now, there may be other explanations for this, but regardless, that mechanism gives us a sense of how you actually use the medications. If you're starting an antidepressant, an SSRI, selective serotonin reuptake inhibitor for depression, it's very straightforward, whether that's Prozac, Paxil, Zoloft, Celexa, Lexapro, Luvox, which is fluoxetine, paroxetine, sertraline, escitalopram. All you do is you look up in your little book, what's the starting dose, you start that, you wait 2 weeks, check on side effects. If that's okay, you leave it in place for about 4 to 6 weeks, and then you see if it's working, and then go from there. That's very straightforward for depression. But what we know with anxiety is initially you can make things worse if you start right away at that starting dose. And if you think about it, if it's partially activating the receptor, that makes sense, right? It's making it look like there's more norepinephrine around. And also, to actually get to the effect, you're not just trying to increase this biochemical, you're trying to take the receptor down, so that can take longer. So regardless of the mechanism, what we really have to do when using these medications to treat anxiety is you have to start at a lower dose than you would to treat depression. I usually start at about half. You have to slowly increase over time, and you end up going for a much higher dose to actually treat the anxiety. So start low, go slow, aim high is a general rule of thumb when using a selective serotonin reuptake inhibitor to treat anxiety. But if done properly this way, they can be very effective. The people who have been generally anxious, who have generalized anxiety disorder, will discover over the course of about a month and a half to 2 months that their anxiety disorder starts to significantly improve, that they start to feel more relaxed, this muscle tension isn't there, and that they see some real improvements in this. And if you leave those in place for about 6 months to a year, just as with depression, you can often cement these gains. So it's not just a matter of covering up the symptoms, that we can actually seem to cure things in many cases. Not all, by any means, but in many cases there's no rebound because we've actually fixed the problem with the SSRIs. There can be some issues in withdrawing them as well, so again, knowing how to stop these medications is important. And in general, the short answer is that you do the same thing in reverse, is that you slowly decrease them over time, the same way you slowly increase them to start to treat anxiety with a selective serotonin reuptake inhibitor. And again, generalized anxiety is about the first level that you'd want to do that. Now, even with this sort of free-floating, consistent anxiety, sometimes you'll get bursts of anxiety that are much worse, what are called panic attacks. Panic attacks often masquerade as heart attacks or strokes. People feel like they're dying. There's at least one theory about how they work, that it may actually trigger something about oxygen sensitivity in the brain, making your brain think that it's not getting oxygen, which is why it's going into full-blown fight or flight mode. But the key to them is that it is a surge of short-term maximal anxiety accompanied by physical symptoms. So heart palpitations, shortness of breath. Again, if you imagine a heart attack, a lot of the things that would go along with that, but they're time limited. So if someone comes in and says that they've been having a panic attack for 3 weeks straight, it's not a panic attack. They might be having a series of panic attacks over a series of weeks, but a panic attack is a discrete period of time, generally reaching maximum in about 10 minutes and typically lasting no more than an hour, most 4 hours by definition. Now, these discrete panic attacks can occur as a part of another anxiety disorder. So if you have a fear of spiders, having a spider suddenly crawl across your nose could cause a panic attack. You might not have any anxiety disorder at all. You're out rock climbing and all of a sudden you discover, oh shoot, I'm not actually locked in and I'm 2,000 feet above the ground. That could cause a panic attack. But they also could grow out of generalized anxiety, that you could be just running anxious all the time and occasionally get this burst that comes through, or another anxiety disorder, what used to be anxiety disorders, but we've classified elsewhere. So something like post-traumatic stress disorder, which is now classified as its own thing, and we'll do a separate series of lectures on both post-traumatic stress disorder and obsessive-compulsive disorder, which have been moved out of the anxiety disorders because they have such distinct characteristics. But generally, you could have panic as part of those. But sometimes panic in itself becomes an essential condition, that these panic attacks just seem to come out of the blue. And panic attacks are such awful things to have happen that you can start developing anxiety about the anxiety. You're afraid to go outside because, well, my goodness, what if I have a panic attack? I don't know what causes this. They seem to come out of the blue. And so you get anxiety-induced anxiety. And that's panic disorder. So when the panic attacks are essential in and of itself, they come out of the blue and you develop anticipatory anxiety, sometimes with agoraphobia, with fear of going outside, or sometimes with more generalized anxiety symptoms. So both these things actually can end up looking quite similar. You can get panic disorder with agoraphobia that looks pretty generalized, or you could get generalized anxiety disorder with panic attacks. But there is a distinction between the disorders and why we classify them differently. So again, in panic disorder, where the panic attacks are the primary thing, that it's anxiety-driven anxiety. And I talked about earlier in terms of, that we treat these conditions with therapy primarily, and that is still the case for panic disorder. We still want to ideally discover the pattern to say that they're not truly out of the blue, that we can discover when they happen, and therefore you can learn to control them. You can learn some techniques to relax before it happens, because once you're in the middle of a panic attack, it's almost impossible to control through, say, meditation or breathing. But if you learn when it's about to come on or what the pattern is, you can often think or use techniques to get yourself out of these. And just as I was talking about with generalized anxiety disorders, if you're going to use medications, these selective serotonin reuptake inhibitors are still considered first line for panic disorder and are very effective over time. And if you look at the studies, they'll say that if you look at, say, tranquilizers versus a selective serotonin reuptake inhibitor, the outcome in a few months is just as good with the selective serotonin reuptake inhibitors. On the other hand, you don't have to be on these forever. They're not addictive. They're not cognitively impairing. So those are still considered among medications first line. But I'll tell you as a clinician, when you get to panic disorder, it can be very tricky to get people to accept that, because these things are so cripplingly awful that, especially since the medications like the selective serotonin reuptake inhibitors, if you're very sensitive to it, might make it a little worse if you got the dose, say, too big at the beginning. It's hard to get somebody to take it. It's hard to get somebody to come out of their house to go to therapy. So this is the first level at which the tranquilizers sometimes can really be helpful. Again, they're still very tricky, and you should probably know what you're doing if you're going to use them, because ideally you don't want to leave somebody on these long term, because they are addictive, they are sedating, they do cause cognitive problems, particularly in the elderly. But sometimes even just having them, you may never actually take the pill. It's kind of like Dumbo's magic feather. If you've got it, you have the confidence to get through. And if you know, hey, I've got a very powerful tranquilizer in this little bottle that I'm carrying around, you're not worrying about having the next panic attack, and you can actually cure it without ever actually taking the pill. But how often, while we're waiting for the selective serotonin reuptake inhibitor to be effective, if you've got panic disorder, I'll start a mild tranquilizer, maybe something just like Visceral, but maybe clonazepam if it's particularly bad, with the idea that you're going to take this for, say, a month until the SSRI, the selective serotonin reuptake inhibitor, really becomes effective, or until you're able to get into regular therapy sessions. This allows you to get outside the home to do that. And again, if you're thinking about the way you dose the medications for SSRIs, it's exactly the same. When you're talking about tranquilizers, you can either use them as sort of a steady state thing, so you're taking them on a scheduled basis, and often that the advantage to that is that if you treat the anxiety before it becomes full blown, it's often a lot easier to get a handle on, especially considering the panic attack often comes on to maximum effect in about 10 minutes. And if you're thinking about it, if you've got some food in your stomach, even for a very short-acting tranquilizer, like, say, Xanax, alprazolam, which, again, psychiatrists hate for various reasons, that it's going to take a while to absorb. So by the time the medication is actually in your system, the anxiety attack may be over. But you can use these medications on an as-needed basis if you know what you're doing in terms of talking to people about anticipatory anxiety. Again, about that sort of magic feather confidence effect of carrying it around in that regard. But if you are going to use tranquilizers, always inquire about histories of addiction, about operating heavy machinery, about anything else, about cognitive impairment, where that might cause a serious problem for the individual who's taking this. But as with the other anxiety disorders, our mainstay should be therapy, cognitive behavioral therapy, selective serotonin reuptake inhibitors, and you really can get these panic attacks and panic disorder under control. So in reviewing, the anxiety disorders we've talked about before, we've talked about that anxiety can just be a normal symptom of things, but you can have anxiety around a particular issue. That can be phobia. The most common phobia is social phobia, fear of something like this, about public speaking. And that's generally treated with therapy. When you start to have more generalized anxiety, where it's there all the time, almost seemingly like part of a person's personality, it's just persistent no matter what, that's generalized anxiety disorder. And that's the first level at which some medication can be really considered possibly first line, though therapy should still be the same thing. It should, still be your main treatment if it is available. And then we get to panic disorder, where anxiety becomes in distinct bursts. You get induced anxiety, and we still use therapy medications and occasionally the tranquilizing medications for that case. Now, there are a couple of other anxiety disorders that are in there, like separation anxiety, that is mentioned in DSM under the anxiety disorders, used to be classified as a childhood disorder, and I'm still going to talk about it there. There's also illness-related anxiety disorder, what used to be called hypochondriasis. A hypochondriac is. And again, I'm going to talk a little bit about that more in health psychology, and the two disorders that have been split off from the anxiety disorders now into their own categories of post-traumatic stress disorder and obsessive compulsive disorders. So please check in for future lectures on that. But in general, remember that anxiety disorders are very common, the most common conditions out there, and are very treatable. People don't always come into a doctor's or a therapist's office for these things, but if you look for them, if you ask about them, you will often find them, and they are very treatable. So thank you for listening in today, and I hope that you will continue to learn and listen. Thank you.